Welcome to the Community of Excellence podcast, where lived experience leads the way. I'm your host, Nil Suner, and together we'll be exploring powerful conversations at the heart of mental health, recovery, and peer support.
Hope for a generation, just beyond my reach, not beyond my sight. Hope for a generation.
Welcome to Community of Excellence podcast. I'm Nil Suner, and today I have Femi Gbadamosi. Full disclosure, we work in the same team with Femi. He is my senior, but we are here as friends and to discuss his journey into the lived experience workforce. So welcome, Femi. Could you introduce yourself? Tell us what you're doing at the moment, what your job is at the moment, and tell us how you came into lived experience work. What was your journey like?
Yeah, so firstly, thank you for having me and thank you for pronouncing my name correctly. My name is Femi Gbadamosi, so it's a silent G. So on documents, you might see a G before the B. And I'm a lived experience workforce lead at a North London mental health trust.
Okay. And what does it mean? What do you do? How do you tell to your parents what you do? Let's start there. Because I have challenging conversations with my family when I'm explaining what I do to them.
Yeah, no, completely understand. So I would explain I'm supporting peers, and peers are individuals who share their lived experience with their job roles within the organization. I also support recruited managers, so managers who might not necessarily have disclosed lived experience themselves, but I help them with recruiting and onboarding of peers. I help the peers to settle in with induction, ensure that they have the right supervision and they have the right supports for their needs within the service.
Right. And one of the reasons I wanted to talk to you in one of the episodes is you have a very specific journey into lived experience workforce, and it might not be very widespread knowledge. And even until I met you and worked in the trust, I didn't even think about it. So you came through the forensic route,
Yeah.
right? Forensic services. Could you tell us how you decided that this would be your career?
Yeah, I sometimes blink and think, is this really me? So to go back to the beginning of the journey, I was in uni studying accounting and finance. I had a completely different career journey. I thought I would have been heading down or heading towards, just handing in my dissertation in year 3, and I fell unwell and ended up in forensic mental health services. I then spent about a year, 8 months. And during that time, I contemplated, what will I do? What sort of options are now available to me? Thankfully, I actually passed my accounting and finance course and I started doing the next step, which is ACCA. So for those who don't know, it's for Association of Certified Chartered Accountants. And that's sort of where my passion lied. I was always good with numbers, did really well in maths. And I just thought, yeah, it's something I really wanted to take up. And when I fell unwell, I ended up in services, and it was a constant conflict of, now I'm in services, there's usually in recent times a question around, what would you say, or what was the reasons for your unemployment in the last 5 years? And or where have you been? Why has there been an education or working gap? I thought I need to kind of slowly get back into things because of a year, 8 months have been spent in hospital, and the opportunity came around to do some expert by experience work, which is now sort of a taboo in the settings that we work in. We like to call it service user representation work. And I guess I thought, why not? Let's give it a shot. It would make for a better conversation during disclosures. And I started by doing interview panels and going to various meetings, sharing my experience from my perspective in services. I guess the professionals, the clinicians within those spaces sort of realized that I was someone who could articulate myself, but also wasn't necessarily affected by going into details, which, as they shared with me, helped them to, develop the service. I really enjoyed it. It was a real feel-good factor. I found being able to share my lived experience of mental health, so my journey through hospital with others really gave me a positive feeling. It gave me reassurance that I was helping others who possibly would come after me or are currently in services. More opportunities came around, and then uniquely, the service that I was actually an inpatient in put out a job advert for a part-time peer role to support their medium secure forensic service users. And I applied, and thankfully I was appointed to that role. And one thing I really enjoyed about that role was it was my first kind of insight into the healthcare sector. As I previously mentioned, I'm from a financial background. Financial sector is all I know. And I was able to develop the role. The role had things that I was told I needed to fulfill, i.e., I was having group and one-to-one supervision sessions with service users. I advocate for them in things like their ward rounds, their tribunals. I was Rio trained, so I had to do some of the mandatory trainings. Like I was Rio trained, I was key trained. So because it is a forensic unit, you need keys to get around the buildings, airlocks and things like that. So I done all of that. But then there was an opportunity to kind of develop the role. And that's the part that I enjoyed most. It was kind of looking at my skills and what I could bring to the table and how I could use that and transfer that into something that's meaningful and supports the service users and my fellow colleagues. And I started sort of fit, suggesting things through the lens of what is still very lived experience related, holding on to my peerness, but does provide a therapeutic intervention for service users. And, some of my suggestions were rejected, some were accepted, and I really felt I thrived at that post. And then from that, the opportunity came around to do that in more of a coordinator position as a coordinator post had come out full time, and I decided to do it. And while this was all happening, I still had sort of one eye on my finance. I was still taking exams. Thankfully, I was passing those exams because this started as almost like a gateway back into the financial sector, as I mentioned. Now, my experience was you had been in services for a year, 8 months, but now you had been actively working on and off in mostly a part-time capacity, working in services which you was once an inpatient in. And I felt like that really added some depth to what would be quite a complex disclosure note or disclosure meeting if I was given an opportunity. Whilst I was in the coordinate position, the light bulb just kind of went off, and I realized that this is what I want to do. I used the funny analogy of how could it have been such a hard choice given that finance is just doing spreadsheets for people and corporate tax when, this vocation I now see is my true purpose, being able to um have that relational and offer that relational support to people who I was once like. And I guess I'm maybe not once like because I'm always considering myself still a service user in some capacity. I mean, I'm not engaged with any services. However, I still, look after my mental health. There's this idea of scientific recovery and naturalistic recovery. So, for example, breaking your leg, a bone snaps and then it heals again. That would be arguably a scientific recovery. It's like there is no end point to the growth within my mental health journey. And I then went into more of a managerial role. So I think within peer working, you kind of hit a ceiling really quickly of what you can offer clinically due to legal requirements to be able to offer more. So I started thinking about a more strategic and operational route in how I can help services. I went from frontline facing, working directly with service users, to working with peers who work with service users, and also management who provide the support and guidelines for these peers. I found that interesting for so many reasons. I think you find out very quickly that in many cases, peers aren't supported for all that they do. Peer support in mental health services can reduce psychiatric re-hospitalizations by 40%. And this was based on research published in the Psychiatric Services, which is a peer-reviewed journal from an American Psychiatric Association. And that sort of stat just blew my mind. Hospitalizations can be reduced by 40%
And
when
that's a
kids.
major point in the current government strategy, isn't it? We keep talking about preventative measures, even though we are putting out fires most of the time in the health system,
Yeah,
and it makes a massive difference.
definitely. Here we have a stat as important as that. We always discuss this theory of the revolving door where peers can't get away from services, becoming impatient. It seems as though, for many reasons, that for a large majority, as the stat would suggest, that they do come back to our services, and establishing that relational support, that mutuality from peers can really decrease that. However, when I started working in my managerial role, so I was a peer and lived experience manager, we started to realize that peers aren't being supported and we was losing peers. There's a stat which just isn't coming to the top of my head at the moment, of peers leaving roles and roles not being backfilled, maybe, becoming other clinical roles such as um, healthcare assistants, or some of that money might be added to another budget and recruit nurses. It just blows my mind. It feels very tokenistic, and for that peer they can feel very undervalued and othered, and they're not needed within the service.
No?
From there, I then applied for my most recent post, which is peer lived experience workforce lead. That role is essentially, I'm challenging in a professional and constructive way the system that wasn't built necessarily for peers and lived experience staff. So if you can imagine, peers is still a relatively new thing working within services, and policies have stemmed far back 50, 60, 70 years. And it's finding adequate solutions to ensuring that peers are supported within those services. So bridging the gaps with senior management, who kind of decide on these ratifications of policies. They have their own perspectives, and we sort of discuss through how changes can improve our services and better well equip us to supporting peers, essentially bridging that gap between peers and senior management.
Yeah. Thank you for that. So, just to paint a picture in people's minds, because a lot of people might not know about forensic mental health services, how does the peer work happen there? Is it about having one-to-one sessions with individuals? Is it setting up peer support groups or peer activity groups? What would it look like? And were there any patterns you saw when you were working with people coming up in sessions or in conversations, I mean?
So, okay, so patterns from peers, not.
Yeah. For instance, I worked in the community and isolation was a big pattern and a factor. And
Yeah.
it wasn't easy to control. It was something that you can only uniquely manage. So you can't have a blanket rule for people to reduce isolation, something like that. Yeah.
Yeah, I think one of the biggest qualities that I've identified in peers that I've widely supported is bravery. And I use that term a lot because for an individual to go through something so real and so potentially disruptive to their well-being, and for lack of a better word, make it through to the other side and then choose to constantly somewhat be reminded of that ongoing experience through a working capacity is absolutely incredible. And a pattern that I've seen within our services is that individuals always wonder where is the balance in terms of how much should they be sharing, boundaries. And through many, many, many conversations, we've thankfully helped and coached and trained peers to, put up that wall if needs be. There's only so much vulnerability you can share without it inevitably having an impact on you. And when speaking to peers, they always discuss this is something they need, almost a soundboard, reassurance daily that could happen through supervision in their understanding quite easily. And I'm astounded to think that so many of our peers don't have regular supervision, have got to kind of navigate an environment that they hold so dearly and is so real and personal to them that it it kind of makes me question how far have we actually come. There's a lot of statistics to say that peer workforce within mental health has grown over 200% since 2012 to 2022. What does that growth mean and what does that entail? Because the individuals who have to be so resilient and so thick-skinned around their lack of support in order to still put what for them is a priority, supporting service users, supporting the service that look after service users, clients. Some people refer to them as residents, depending on the settings that you work within. Putting them first, it's quite a recurring issue.
Yeah. And how would someone under forensic mental health services who is interested giving it a try to become a peer support worker or to do some sort of lived experience work, it could be service user representation or something else, where would they start?
I think it would be firstly embracing their authenticity. No two experiences are the same. They're an expert in their own lived experience. And there are services who would love to have the support. And it's about looking at what is available. Typically, you can go on the NHS jobs website. You can even just a quick Google search can provide opportunities to apply for roles. And I think also prioritizing self-care and putting yourself first. It's okay now within many roles, there's a probation period and it's okay to not complete a probation period if it doesn't work out being for you because it is quite full on. You asked about themes that have come up, but then there's also aside from boundaries, but individuals who don't feel like sharing their lived experience and utilizing that experience within their roles. So I would say prioritize that self-care and knowing when maybe you're slipping and just knowing that services are very adaptable. So different roles will look to work with you and find out what are you best at, for some individuals, one-to-one and group sessions where they can chair a meeting, teasing out important insights from individuals within that space to support others is their strong point. For some, it's writing notes, really being able to articulate a discussion that they had. For some, it's presenting their findings to other teams, neighboring departments. And it's about sort of thinking about what are you good at and knowing that it would work somewhere. And I guess that is the start of being able to work within a peer role in an NHS or mental health service.
Yeah. And it could be in a charity as well.
Yeah.
Would there be, I remember seeing posters and invitations for recruitment for either service user representation on the ward or peer activity worker kind of announcements. And we also work with a collaboration, don't we?
Yeah.
that might expand the opportunities. Can you talk about that a little bit in the specialist services?
Yeah, so within specialist services, there are several types of peer roles. There's learning difficulty roles, there's forensic, there's eating disorder services, there's autistic services. So there's a range of different services that your experience, if that's the experience you have, can really work well and help with that settings.
Some people, they don't all work for one trust. I think there is a collaboration between trusts, different trusts, because I remember, for instance, a title that you wouldn't know lived experience work, which is, I think, community navigator or community
Oh,
engagement worker.
yeah. Community engagement practitioner.
Yeah.
Yeah. Um, yeah, so there are different roles. You've got your peer support worker, you've got your peer coaches, but then there's also activity coordinators, which is slightly more tricky and requires more support because these are roles that wasn't necessarily restricted to lived experience individuals being able to apply. Or for those who don't know, is similar to a technical instructor role. However, they've on the peer or the individual with lived experience who's willing to share it, who's appointed to that role, would have to adapt the role using the peer principles. So like that mutuality. So being able to encourage individuals on the wards to engage in these activities through the use of that representation that they were once in a similar position to the service user.
So I know you have some information in front of you. Is there anything else that you find interesting that you want to bring to the table?
Yeah. So I mean, I do know this is a big one. So working in the role that I'm in now, unfortunately, there is a lot of cost constraints, not only on peer working, but across the NHS in healthcare in general. Interestingly, incorporating peer support can lead to up to 10% savings in mental health service costs. And this is mainly due to reduced acute care needs. So, and this is something that I've had in my experience being able to facilitate groups where we can have an open, candid conversation with peers and then have an open, candid conversation in another group with service users and talk about experiences. And I've had feedback like I've never looked at it in that light before. And you really get me, you really understand me. We always talk about protected characteristics and how this forms representation and identifying a similarity. So for the individual, the service user, identifying a similarity within the person they're working with. So in that case, it would be a peer. So we always talk about someone actually mentioned an interesting thing in one of the sessions that I'm happy to share, which was how relevant would my experience of psychosis as a male be in a group of women who had experienced postpartum depression
Interesting.
or postpartum psychosis. And that really kind of hit home and highlighted how important it is to have representation within these interventions because, as mentioned, being in a space where people can identify, say, maybe because somebody you can have all the information in the world, and if somebody just can't connect with you, then it's useless. And I've had to accept that, you know, what characteristics about me are not going to be as beneficial in a space as opposed to others. And I think within services, something that's so unique, almost described as a superpower, which is, openly accepting that I've had mental health challenges and I'm willing to share that within my work because I don't want to misrepresent any other individuals. I know many people suffer from some type of mental health or have had mental health crisis in the past or have had fleeting moments where their well-being has taken a fall or a dip and they still understand how their mental health can be affected. And that doesn't make them any less qualified than someone who's disclosing it within a working capacity. However, for working within a peer role, if you're sharing your lived experience, it's more apparent to the individual you're supporting. Many times I've had feedback to say, I really get it, and I'm really going to just something as simple as I really am going to stop hiding, not taking my medication. I'm going to have a conversation and explain to the consultant how I feel about it. This is something where looking at a statistic like reducing mental health costs by 10%, ensuring that service users stay well in the community for as long as possible is one way of bringing down costs.
Yeah, yeah. So for the next step is I want to ask you about a great day at work. Can you what a good day looks like? How does it feel like? Do you remember any day stuck with you?
Yeah, for me, a great day is seeing my connections that I've made with peers be rewarded the reward for me is seeing them progress and go on to, develop themselves. And that trickles down to service users that they've worked with. I've also had this experience myself, but service users they've worked with being discharged from services. So seeing them at what can be considered quite a low point in their lives and then start to thrive in the community and then be employed. I've worked with service users who are now my colleagues in the organization that I work for, which that's an amazing feeling. I wouldn't necessarily say that's any one day, but that's an experience that is constantly happening. Yeah, just a day when it's genuine laughter and positivity from the people around me, being able to discuss how we're waiting on information. We've got deadlines that are due. It may not all be going smoothly, but everyone is still genuinely happy because that shows that I know the right people are in place to support the service. And that's such a, like I mentioned earlier, a feel good factor for me.
Yeah, thank you for that. So I will now move on to the theme bit where you picked resilience, but we're gonna need some context. One of the things that comes up all the time with the clients I worked with the peers I worked with, and other colleagues is it is an easy word to utter in many different contexts, but it's also a very unique experience. And sometimes I think it is misunderstood because it feels like it means pushing yourself all the time, which I personally don't agree with. But definitely it comes up a lot in the work we do. We have to be resilient to do the work, but also we have to be resilient to kind of exist with our health conditions and move on with life as well. But what was the context you were thinking about resilience as a theme?
I guess the context I meant it in was having worked in more of a frontline facing role, working directly with service users. It's wanting to do right by the service and service users, but knowing that things haven't gone well for myself. And I use this term of sometimes feeling othered in that my challenges are not a priority.
Hmm.
And it's about having the resilience in that moment to continue to try to perform my role as best as I can. Whilst in many, many cases, this could be challenging to one's mental health. And that could be a scary place because for someone whose mental health had maybe a severe challenge in the past and led to an admission into hospital and that being pushed daily, it's quite hard. But I've seen that characteristic in many of the peers that I work with, that resilience to be able to um, know that things aren't right and may not know when things will change, but are still willing to push through that experience to what they can only hope would be a better one. in future. We've had another part of my role is working with HR and occupational health around adapting reasonable adjustments and looking at what are the best ways to resolve things around peers not feeling supported. A lot of our peers are working in silos. They are in many, just to give an example, many MDT teams, there might be two halves, a case to a caseload of clients or service users where one half of the caseload have one psychologist and the other have the other psychologist. And there's an OT and then there's a TI, and then there's two consultants. Very rarely would you find that there's two peers. So to kind of validate their experiences, they come to spaces that we offer. We, as in the team, my team, which supports the wider workforce, and sharing those experiences and not necessarily having an immediate answer. They have to somewhat be patient, and it can often feel like you're pushed into a grey area where I guess the big machine that is NHS Mental Health Trust just keeps on, the cogs keep turning, and you can feel ostracized and othered. But then that resilience is what I see is the one aspect that keeps individuals going.
How about how you feel about kind of when you think about your life, your journey, your personal resilience? One of the things that come up a lot for me, both at work and in my mind personally, is yes, there are a lot of areas for improvement. Some of them are very, very urgent indeed, like providing the right support network to the colleagues. But some of the shortcomings in the system, even though we do suffer as lived experience workers in a specific way, it seems not specific to lived experience workforce. The lack of support, the lack of clarity about the roles, or the huge workload, constant building workload is, these also sound like big healthcare system needs or realities as well. And I find myself, going between the two lanes a little. One of the recent themes that come up a lot in my recent conversations is that we all love the work. We are passionate about the work. And it's very likely everybody who is doing this work were actually doing it in some form in their personal lives before coming into work, but kind of the training gave it a formation, the work setting gave it a formation, but the values were there, probably the characteristics were there. But I found huge meaning when I came into lived experience work, and I can comfortably say that it kind of contributed my recovery, and it does on a daily basis. Doing this work, as challenging as it is, helps me, my mental health as well. However, maybe because I'm becoming 40 this year, but I'm also thinking about the life progression as well. The lack of clarity on career progression, and also the difficulty explaining and translating what we do because it isn't based in measurable work, so to speak. Measurable in the sense of, university degree based jobs, numeric outcomes. There are research, but I think not many specific to the work settings we are in. Like we can find research in the international literature, but if you try to localize that research, there isn't as many. And I know people are working on that. So I find myself working on my resilience to be patient, not to solve stuff recently, and try to kind of being able to live with those questions. How does it work for you? How do you keep your personal resilience up?
My personal resilience comes from, as you mentioned, yeah, you mentioned some really key points. There isn't a lot of qualifiable courses run by institutes such as universities that can further develop your competence to working in a lived experience role. I actually mentor several individuals within our service who are working in lived experience roles. And I'm constantly every day trying to source information to be able to support them And whilst in doing so, I do stumble on things that can help my own personal development. And like I'm currently nearly at the conclusion. I'm just at the dissertation phase of a master's with the master's is in global mental health and well-being. And, more and more there's being able to sort of go through that course. It has brought me to so many up and coming pieces of research. I think there's more research happening, government funded projects that tap into the experiences of individuals who work in mental health spaces in the voluntary sector as well as healthcare public sectors. And that information is being extracted and the data is collected, and it will help understand what is going on in terms of the development. I always say, yes, entry requirements into a lived experience role is willing to disclose that you have a diagnosis of mental health of some sort, or a personality disorder. And then for me, that's when it becomes a bit stagnant. You think, how can you further develop? So I started looking into well-being. I started seeing how can I develop around well-being, because I guess this is at earlier stages, but I kind of compare it to, just to use this example, the managing director of a division. Within the trust that I work at, there's 9 divisions with 9 different managing directors, and they come from all different backgrounds. So there's not necessarily a one shoe fits all approach to what can get you to a position like that. Then there is the idea that peer support. I mean, this is I guess an open debate that people have been having, is at what point do you branch out of solely using your lived experience? I know for a lot of those managing directors, they have qualifications of leadership. So leadership qualifications. And for a peer initially, that might seem uncommon. Why would I need a leadership qualification to work within a peer role or a senior peer role or a senior lived experience role? And these are transferable skills. I like to see it as we're one part of the organization, and it's about further finding qualities to complement your lived experience, which was initially what drew you to a peer role. I think qualifications in management, well-being are things that are ways that peers can develop themselves. And that's where my resilience comes from. Is I also have a mentor who supports me and kind of guides me and gives me advice on how to elevate myself, so I don't feel like I'm stagnant and I'm progressing. I always have a studious mentality in trying to constantly learn and develop and work on the craft, the skill set that I bring to my role.
Right. Thank you for that. So before we wrap up, is there anything else you would like to share?
Maybe just reach out to a peer if anything I've said today has kind of triggered a thought or has been thought provoking. Definitely you can reach out to me. However, I would say if it isn't as convenient, you can definitely reach out to a peer or a lived experience practitioner, someone working in one of those roles, and gain their perspective on services and their experience in roles.
And for that, you can also Google Community of Excellence, sign up to the newsletter to hear about networking events, trainings, and opportunities. So thank you, Femi, for today, for this recording, and thank you to our listeners.
Thank you. It's been a pleasure. Value this opportunity, and I'd love to be on here again if you ever needed me to.
Thank you for joining us on this episode of the Community of Excellence podcast. We hope these conversations help break stigma, build understanding, and remind you that healing is possible, especially when we come together. If you have been affected by anything in this episode, please know you're not alone. Support is available. You can speak to your GP or a mental health professional. For urgent mental health support in North London, contact the crisis line on 0800 151 0023. You can also call Samaritans anytime on 116 123. For free confidential support, you can text SHOUT to 85258. You can also call Calm Helpline on 0800 585858. Until next time, keep connecting and keep believing in the power of lived experience. This is more than a conversation, it's a movement.